let me invite Professor Hiroto Egawa, who's going to speak to us on antibody-mediated rejection in ABO incompatible liver transplant. Professor Egawa is the head and chair and professor at the Department of Surgery, Tokyo Women's Medical University from Japan. Let's hear how he deals with the AMR, and let's start with the discussion. Dr. Egawa, please.
Oh, thank you very much. Please start the video.
Thank you for the opportunity to share my knowledge and experience about ABO incompatible liver transplantation. Today, I congratulate Professor Gupta and Saiga that you have the transplant hepatology course 2021. I have nothing to disclose. Today's issue is pathology and diagnosis and management of ABO incompatible liver transplantation. This is a mechanism of AMR, antibody-mediated rejection. The B cell are developed to the plasma cell. The plasma cell make the antibody. The antibody connect to the antigen and the surface of the B cell tissues and make inflammation with help of complement and inflammatory cells and destroy the surface of the B cells and make a thrombus in the organ who was injured by circulatory disturbance. The complement play a very important role in AMR. This shows the cascade. And C4D is a very unique substance. Usually the complements are diminished immediately after reaction, but the C4D remained the place. This is a very important substance for the diagnosis of AMR. This is such a carbon after the fire. This one shows the stain of the C4D, IgM, or IgG along the sinusoid of a patient who died of severe AMR after ABOi. This is the typical HE pathology, and vasculopathy is a key. The left panel is hypertrophy of the hepatic artery. The right panel, inflammation of the hepatic artery. Especially the bile duct is received in the blood flow only from the tiny hepatic artery. So the injury of the vessel is very limited to the small arteries. The patient developed a bile duct injury, but the patient developed the massive blood flow injury. So the patient developed the liver necrosis. This is not different. This is longitudinal findings. This is the very important finding, early pathological finding of AMR. Professor Haga, the Kyoto University, reported 2006. The small thrombus of the artery, the edema, and necrosis, and C4D stain. This is severe AMR, the hemorrhagic necrosis. So once we see this, we have to change the liver. Diagnosis management. This shows the time course and AMR, the types of AMR. So the pre-existing DSA might play a role, but usually the de novo DSA has important role for the AMR. But anyway, we do the desensitization targeting the B cells, memory B cells, to decrease development of the de novo DSA production. This is just theory of the B cell desensitization. So the tacrolimus depress the development from B0 cell to B1 cell. Rituximab kill the B cell. And the Cercept suppress the B cells, all B cells. This is our current standard regimen for prophylaxis in ABOi. So we give the rituximab 2 weeks before, usually, and we might do the plasma exchange when the patient's titer is very high. The important thing is we give the tacrolimus and the Cercept before liver transplantation, if possible, at least 1 week. The dose is not shouldn't be so high. And now we do not do this. No, we don't do the splenectomy. B-cell depletion is a key. I show this is an old slide without rituximab. The patient developed a B-cell increase just immediately after the reperfusion. 3, 6, 12 hours, the increase. So I gave the rituximab to patients. So we have to give the rituximab before the transplant. This is my painful case, 2000. So I did not give the rituximab because her titer was very low. But the number of the B cells increased immediately after transplantation, and also memory B cells increased. I gave the rituximab. The number of B cells, memory B cells decreased, but the titer increased, and the patient developed a severe AMR, and the patient died. After the case, I give rituximab for all patients. And rituximab depletes the B cells in the spleen. The control is the hepatitis C patients who received the splenectomy for the postoperative interferon therapy. So all cases, anyway. And I also checked the B cell subset in lymph nodes, usually around the portal vein or the stomach. Surprisingly, rituximab did not decrease the B cell, the memory B cell, and the lymph nodes. This is the time relation between the B cell, the depletion, the timing, and the rituximab. So if we give the rituximab early, we can deplete the B cells enough. But if late, some patient, the B cells increase. The optimal dosage regimen. It means what is the safe minimal dose? That's one slide. So this is a 375 million per mil square. There's a 5 milligram per body, a 300 milligram per body, 100 milligram per body. I calculated, and that red asterisks show the AMR here. So we need 185 milligram per square of rituximab for safety. And the patient survival also significantly different between the patient with enough rituximab or small rituximab. Prophylaxis might reach to the upper limit. What is the next treatment for AMR after transplant, or how predict risk of AMR? This is the devices to combat to AMR. You know we can use rituximab, splenectomy, plasmapheresis, IBIZ. And the bortezomib, still we have small evidences. The IDES, a C1 inhibitor, C5 inhibitor, IL-6 inhibitors. These are the very promising, but very, very expensive. This is my idea for strategies for possible or clinical AMR. When the patient developed inflammation, a fever, the CRP elevation, with or without liver function increase, just give the steroid pulse and the liver biopsy. Actually, do the liver biopsy fast and give the steroid pulse. If the liver biopsy shows the portal necrosis and edema and the C40 positive, this is the early phase. And after we already gave the steroid, to watch. If the patient improve, it's okay. But to develop, we need the next step. Or this biopsy show the hemorrhagic necrosis. We just do the plasmapheresis, IBIZ, rituximab, the bortezomib. I show the one case report of bortezomib from Kyoto University. They are successfully treated the patients who developed the AMR resistant to the steroid pulse, plasmapheresis, the rituximab after transplantation. Just 2 doses of bortezomib decreased the antibodies, and the patient was saved. And no severe adverse effect. How do we predict a risk factor? So I show my painful case. After the 2000, I haven't had the AMR, but the last year I met 2 cases of AMR. First one is a 40-year-old lady with PSC. I gave the 375 milligram per square, and the schedule was postponed 1 month to ensure safety against the COVID-19. The BCL was 2% before transplantation. I did not add another dose. I regretted it. And no transfusion during the liver transplant. Just blood loss was 500. No splenectomy. We measured IgG subclass and C1 binding IgG from this case. So the titer at the maximum to 128, it is not so high. But the patient developed a fever, the liver function increased. So, I did the liver biopsy and fully treated and steroid pulse, PEGs. And again, she developed the liver function dysfunction. So I gave the rituximab and IBIZ. Clinically, she improved very nicely. But before the discharge, she had the fever, the liver dysfunction again. And we treated the fully, but we gave the bortezomib. So let's see the IgG subclass, IG3 subclass, and the C1q, green one. So during the first attack, C1q, C1 increased, and after decrease, the C1q and the IgG1 increased again. But after the bortezomib, the both decreased. But unfortunately, she developed a liver abscess, and she was rescued by liver retransplantation from the 66-year-old father. This is the portal necrosis edema and the C4D on POD8. But the second biopsy, I saw the hemorrhagic necrosis. This is another case, subclinical AMR. He is a male but a PBC. Donor is his wife. He had the fever and liver dysfunction. This time, and also he developed the increase of IgG and the C1q. I did the pulse steroid and the plasma exchange and the IBIZ. And he was rescued without any complication. So this is the portal edema necrosis and C4D deposition. So lessons from my case: autoimmune disease such as PSC, PBC could be high risk. A B-cell depletion should be strictly for autoimmune diseases. When blood loss is small, splenectomy could be a choice. Liver biopsy is recommended in any clinical event. Even when antibody titers are not high, increase of C1 binding or IgG or IgG1 subclass could be a risk indicator. This is not a popular method. The bortezomib should be used at the first attack. Complement inhibitors, IL-6 inhibitors could be promising. Thank you for the attention.
Thank you, Dr. Egawa, for a very
Thank you.
useful talk. Are there any questions? My co-chairperson, if they have any questions, Dr. Pankaj Puri can take over from here, please.
Thank you. Thank you so very much for the nice talk, sir.